Thank you very much and welcome.
Okay, thank you, Carl. Hello, everyone. So I'm pleased to speak today about mouthpiece ventilation. As you said, Carl, this is a topic I like very much, and we are using that technique for many times. I will speak about that now. And just to but I cannot go further in my presentation. So it doesn't work. I don't know what happens.
Probably just using the arrow keys on your keyboard. Would that work?
Yes. Sorry. So I made it, but it didn't work until now. So okay, we are jumping in the topic. So my first slide was just to show you the problematic of mouthpiece ventilation, and immediately you see here on the left side of the slide, this man is an adult patient, almost 50 years of age, and you see it's interesting. His vital capacity is extremely slow, less than 1 liter. This means almost 15% of the predicted value. And if you see that man, you see that man is able sometimes to connect on the mouthpiece and sometimes to disconnect from the mouthpiece. And this is very important to show you immediately, because this is the main difference between the nasal mask and the mouthpiece. So here I cut the sound so you can see only the man using the device. You see on the left side, this man is working, is living at home. I don't make any publicity for anything, but you see a trolley with a ventilator, and this man is using his mouthpiece during the daytime. As you can see, he's using such a collar that we have made, and he's just telling that it's fantastic to use that system with two free hands. And you see, when he wants some air, it just connects to the mouthpiece and disconnect for speaking. So it is a system where patients have to play their own role. This is not like the nasal mask, where the patient is passive and has to take the air always from the nasal mask. So when we look at the history of mouthpiece, and I made some PubMed research from 53 until this year, and so you can see different periods. The first period is until 86. We had papers only from the US, and this is at that time it was quite anecdotic case reports, etc. But from 87, we started to have some more articles and studies, only from the US and from Canada, on post-polio patients, neuromuscular patients, and also you see that in yellow, we started in Belgium, in our center in 1991 with the first patient with the mouthpiece. And then until 2012, this experience was spread around the world, and we had at that time more and more studies regarding technical aspects, physiological aspects, and also the use of the mouthpiece in critical care units. Important date, it was 2012, and it's the date where Philips made commercially available equipment for mouthpiece ventilation. This is important because until that time we had to customize everything, but from 2012 we finally had equipment that we were able to order. And so after 2012 until 2019, we had an exploding amount of new studies in Europe reporting more clinical evidence, also the outcome of this technique and the choice of patients regarding different techniques of daytime ventilation. And also in 2016, I will speak about that later, we had some more specific studies regarding the technology. So you can see it's very recent. It's no more than 6 years ago, very recent. And the last period is the last 2 years where we have published some reviews and guidelines, and I will speak a lot about these reviews and guidelines because they speak about the whole history regarding mouthpiece ventilation. So we started in 53 with the prehistory until 87, and in 87 we had a fantastic study from the famous John Bach, and the title of this paper was Mouth Intermittent Positive Pressure Ventilation in the Management of Post-Polio Respiratory Insufficiency. So this paper was made after the very famous polio epidemics in the 1950s. And this is really a very, very important paper in the history of home ventilation, because since this study of John Bach in 1987, non-invasive ventilation, including mouthpiece, you can see on the two pictures, became an important treatment of those patients receiving full-time ventilation, because until that date, patients who had to receive daytime ventilation always received tracheostomy. So it was, for the world, I can say, a big challenge and a new information that it's possible to manage patients with non-invasive ventilation 24 hours, 7 days. So after this period of prehistory, we had some more physiological studies. These were the modern times of mouthpiece ventilation. And in this modern time, the most important observation is that patients are managing their leaks by themselves. So patients, when they want to have air, they just purse the lips. When they do not want air, they just disconnect and release the mouthpiece. This is extremely important to understand. Now I will show you this. So this is again the same slide, the same video, to show you that this patient really needs air. You see his air hunger. He has to play with his secondary inspiratory muscles because his diaphragm is paralyzed. And as you can see, this patient was using the new system, the new collar that you can see here. He was using that system for 5 minutes. And as you can see, it's a little bit too far to do that. So when the mouthpiece is closer to his lips, it is easier, but we will speak about that later. So when we look at a window of 20 seconds with the volume cycle mode with a ventilator, what do we see? We see that patients can have the choice regarding the amount of air they want to take in their lungs. For instance, they can take 100% of the tidal volume, but they also can decide to take only 50%, and the 50 remaining volume is going in the air of the room. And then, for instance, they say, okay, I have enough air. They can totally release the mouthpiece and take 0% of the air. Then, for instance, 60%, then 30%, and then, for instance, when they want again some more air, pursing the lips perfectly and taking 100% of the air. So this slide is important to show you that this is a very dynamic way of taking air. This is not like with the typical nasal or oral nasal mask where patients have to take all the air without leaks. Here, clearly, we just work with leaks. Leaks are normal and patients want to have those leaks. So to have some more information and gather the information regarding the literature regarding mouthpiece ventilation, we had the chance just, it was 2 weeks before the COVID, to have a meeting in Amsterdam with 20 colleagues from all kinds of countries. And the idea was to stay for 3 days together and to write guidelines regarding the use of mouthpiece ventilation. As you can see on the right side, there was also someone invited using the mouthpiece to give also some comments of a mouthpiece user. So the names of people participating, it was myself, Michel Chatwin, Miguel Gonçalves, Jesus González Bermejo, Bendit, Makim, Sancho, Hoff, Sansone, Prigent, Carlucci, Wextra, Garabelli, Escarabil, Pinto, Odak, Verwey van der Ouderen, Onya, Hughes, Deveau, Cholet, and finally Tina Anderson. And so at the end of this meeting, we were very lucky to publish this this algorithm. And you see this is going from point 1 until point 10. Point 1 is when there is a scheduled visit to the Center for Non-Invasive Ventilation, and point 10 is the long-term monitoring of mouthpiece ventilation. As you can see, this is a little bit tricky to read, but this is open access. You can find it back in the original publication. But to make it easy to follow, I decided to speak only on 5 topics. This is the ventilator, the mode of ventilation, the settings, the arm support, and finally the mouthpiece. Let's start with the ventilator. So as you can see, there are different ventilators from different companies. Here on this figure, Philips, Resmet, Breas, Lowenstein, and Air Liquide, but until this publication, there are also other devices. And if you are interested, you can see all the different possibilities of setting according to every brand of ventilator. So I told you in 2012, Philips Respironics invented different systems, the MPV mode, but also, that was extremely important, an arm support to support the mouthpiece close to the lips. And also they developed a new mouthpiece. This is the straw mouthpiece. We will also speak about that later. But there are other companies like Resmet with the Astral 100 and 150. Sorry, with the Resmet Astral and 100 and 150. The Breas Vivo 45 LS and the 55 and the 65. The Lowenstein Louisa. The Air Liquide EOF 150. The Trace Medical Vox SN. So you can see there are many different devices available on the market. All those devices can support mouthpiece ventilation with more or less of these characteristics. The most important items are the specific trigger with the flow interruption detection, but also the possibility to set a rate at 0. Besides that, there are also other possibilities, but I will now speak a little bit more about the specific trigger. So what is this specific trigger? The name of this trigger is the kiss or touch trigger, and the principle is that there is a sensitive flow detection system. So what is the ventilator doing? The ventilator is providing a constant airflow, constant, all the time. And when the patient wants air, the patient has to interrupt the airflow like this. And when he is releasing the interruption of the flow, then the ventilator will give 1 cycle of air. So in the practice, the patient interrupts the airflow with his tongue or with his lips. And interestingly, the principle is that there is no trigger effort with this system, because the patient has not to ask for air, just interrupting the airflow. Just an anecdote, I had a patient years ago who didn't understand that he had to release the mouthpiece after. So if you interrupt but you do not release, you do not receive air. So you have to interrupt and then take the air from the ventilator. We will come back later on this sensitive flow interruption trigger. So the second point is the volume. This is really very important. So if you are a little bit sleeping because you ate too much at noon, this is the most important message from this lecture. Advising the MPV mode is always to try with the volume mode. Never try it first intention with the pressure cycle mode. Use the volume mode. This is not easy because now for years and years with the nasal mask, we are using pressure cycle system. So this is totally different than what we are doing with the nasal mask. If we compare here the volume cycle mode and the pressure cycle mode, and if we look at the characteristics of the patients to use the volume or the pressure, what can we see? And this is also important to tell you now. With the volume, it's not important to have good muscle condition. If you have weak oral muscles, this is not a problem. Also, you can be unable to seal the mouthpiece. You can be unable to engage and disengage from the mouthpiece. And finally, you can be, and it's even better, to be totally dependent from the ventilator. When we compare with the pressure cycle, it's different. For using the pressure cycle mode, you need to have preserved oral muscles. So you need absolutely to have good preservation for the lip pursing. Also, you have to be able to seal the mouthpiece. You have to be able to engage and disengage from the mouthpiece. And finally, it is better to be non-dependent. I will speak about that also a little bit later in this lecture. Another important figure that we made during the closed door meeting with our 20 colleagues in Amsterdam in 2020 was to show that according to the clinical situation, patients, but also the ventilators are not doing the same. So I will try to be very clear here. You see here, point 1, point 2, point 3, and point 4. Okay, point 1 and point 4 are those moments where the patient is totally pursing the lips and taking full air. When he is doing that, there is a good pressurization of the ventilator, and also the flow is quite normal. But look here, when there is 50% of leaking, there will be, with the flow, some leak compensation, and this leak compensation will not be comfortable for patients. And here, point 3, you see that the patient is not connected at all. There is zero connection, so 100% of leaks. And at that time, you see clearly that there is a huge flow compensation. And this flow compensation coming in the direction of the face of the patient is not comfortable. But look, and this is very interesting, when the patient is reconnecting to the device, to the mouthpiece, there is immediately no compensation, so the compensation will stop immediately. And also you see that the pressurization of the mouthpiece is perfect from the first cycle. This is not the case with the volume. We will see that later. Here there is, this is a screenshot of a patient in whom we took a video. And you see this patient sometimes talking and sometimes pursing the lips. Here, clearly the patient is pursing his lips. And you see, as in the previous slide, you see that the flow is not compensated and there is a good pressure. But the patient is talking, so making leaks here, there is a huge flow compensation, and this compensation is not comfortable. So we saw what happens with the pressure. Now what happens with the flow cycle ventilation. Again, you see point 1, 2, 3, and 4. Again, point 1 and 4 are those moments where the patient is totally connected and pursing the lips. But you see here, point 2, the patient is 50% connected, meaning that 50% is leaking, so going in the air of the room. Interestingly, you see here, there is no flow compensation. And here again, with zero connection, so 100% leaking, there is no flow compensation. While here you see that the pressure is not given to patients because it is leaking. And as you can see here, when the patient is reconnected, the flow is going back to normal. But here, and this is very interesting, you see that devices need 2, 3, 4, sometimes 5 cycles to give the normal pressure and also the normal tidal volume. I will show you that later in another study. So the volume mode is interesting because it is not compensating for leaks. So this is more comfortable for patients. But when the patient is reconnecting, it can last some cycles before getting the good pressure and the good volume. Here the same patient, and you see the patient pursing the lips perfectly well. Pressurization is normal and flow is normal. And look here, when he's talking, making 100% of leaks, there is no pressure, but there is also no flow compensation. Okay, now what about the settings? So I told you that there is a possibility with the dedicated mode for the mouthpiece to set a backup rate or to set the rate at 0. And what is better for patients? Do patients prefer a rate at 0 or do they prefer to adjust a backup rate? Well, we tried that in 20 patients some years ago, and we could see that when the rate is at 0, no patient with a free time less than 6 hours could use this rate at 0 because they said that it was too much effort for them to always making this movement of flow interruption trigger. While when there was a backup rate, you can see that here many patients with a free time of 4, free time of 2, and even no free time at all, they all preferred the backup rate to use the mouthpiece. This is interesting, but this is only in 20 patients. So I told you regarding the setting that we can suggest a tidal volume, and among the experts, the expert panel during the Amsterdam meeting, we didn't totally agree on the initial setting of volume. Some said start with half a liter, and some others said, no, you have to start immediately with much higher volumes. And I'm very happy to show you this study from Adam Onya in 2016. And you can see here patients using the ventilator, here disconnecting from the mouthpiece, but here look what happens when patients are reconnecting to the mouthpiece. At the moment they are pursing the lips, you see that according to 5 different devices, you can see that the devices took from 2 until 5 cycles before giving the right volume. Why do I say that for you during this webinar? Because indeed you have to set higher tidal volume because patients constantly are busy to connect and disconnect, meaning that they are constantly using the mouthpiece in these circumstances. So for instance here, if you set a tidal volume of 500 milliliter, during reconnection you only give 250, and then progressively 300, 400, and finally after 4 or 5 cycles you will give the right volume. So it is better to set a higher volume, for instance, 1,000 or 1,500 liters, because you know that it will take time to give the right volume after reconnection. So in real life, patients are always using the mouthpiece in these circumstances. So it's quite normal to set an initial higher tidal volume. Okay, now, what about the arm support? So again, the same study on 20 patients. And again, we ask patients to use different arm support. And we used the Philips arm support. The Philips arm support is a very good arm support, but the problem is it cannot move with the body of the patient. It is fixed on the wheelchair. So if the patient wants to move in the wheelchair, the arm support will not move with his body. It is the reason why we prefer customized systems that are placed on patient shoulders. And when it is placed like this, the mouthpiece is coming in front of the lips. And when patient is moving, the mouthpiece is following the movement of patients. So the question we had to patients is, which one do you prefer? And finally, we had almost 50-50%. 50% prefer the fixed arm support on the wheelchair, and the other 50% almost preferred a system fixed on the shoulder. Just for your information, this system will be available soon because there is a company, L3 Medical in France, who is now busy to make it commercially available, and the price will be, I'm quite sure, a little bit less than 100 euro to have that. It will be possible to order that, I hope, in a few weeks or in a few months. Now, regarding the mouthpiece itself, again, we compared two systems. We compared the classical plastic angle mouthpiece. So we compared that to the silicone straw, and we asked patients to give their preference according to their free time. And we saw, okay, if patients have, for instance, 6 hours of free time, we had the same amount of patients preferring the straw than preferring the angle mouthpiece, and there was no difference according to their free time without the mouthpiece. We hypothesized that probably they would prefer the straw regarding the opening of their mouths, but it was not the case because here is the opening of the mouth from 0 to here almost 4 centimeters, even 4.5 centimeters, and you can see that there is no difference for the choice of one or the other mouthpiece according to the possibility to open the mouth. Why is it important? Because it's important because if 50% are choosing for one and 50% for the other one, it means that you need to have both mouthpiece to start ventilation with new MPV users. So there are many different mouthpieces, and all the companies have developed their own mouthpieces. If you are interested, there is a fantastic website. The name is CanVent, and you see here our colleague Doug McKim from Ottawa explaining different things regarding customized mouthpieces. So this is open and free access. So I told you we started mouthpiece in '91 already, and you see here many patients we have where we have implemented mouthpiece ventilation, and you see that every patients have different system. Sometimes they are using the mouthpiece on the right side, sometimes on the left side, sometimes in front, sometimes coming from the bottom, the bottom, as you can see here. So here you see coming from the bottom. So you have many different systems. It means that you have to make a work with your patient to customize a little bit the position of the mouthpiece. A question we often have is, how long do you need to start with the mouthpiece? From the moment we explain the system with the dedicated MPV mode, the specific trigger mode, etc., and we try a rate at 0, we try a backup rate, we try the plastic mouthpiece, we try the straw mouthpiece. In total, we do not use more than 2 hours. So it is really a short training period. We published in 2006 already a study in the European Respiratory Journal on 42 patients with Duchenne dystrophy using this technique. And we said in conclusion that mouthpiece ventilation was safe, can prolong survival, and also can stabilize vital capacity even for 5 years. This is interesting. So it means patients who are tired during the daytime, you see they make some movement because they are air hunger. If you place the mouthpiece only 2-3 hours in the middle of the day, they also can stabilize their vital capacity when they have Duchenne muscular dystrophy. Naturally, with ALS patients, it is not the same story. This is to show you a special case we had some months ago. This is a young child. She must be almost 6 years of age, and she received a tracheostomy at the age of 2, and she progressively recovered from Guillain-Barré syndrome. She is totally paralyzed with her arms, but she has a good strength with her legs, and we tried with the mouthpiece just with the hope to decannulate, and I think that now she is already decannulated, and so I will show you this very short video. I will show you it again. This is another patient, I would say a child, because she has the body of a child. She's 70 years of age, but only 60 kilo. Her name is Aisha. She gave me the permission to use her picture. And she is a fantastic mouthpiece user, using the mouthpiece in front of her mouth. This is another fantastic slide of a patient that I have been implementing the mouthpiece with him in Prague 6 years ago. And this guy was 19 years of age at that time, was 20 kilos, and only the fact that he's using the mouthpiece during the daytime, it took some 20 more kilos. And you see here, he's enjoying the snow with his mother. But you see, he's using the mouthpiece here on his sledge, and he's doing the same on a kind of sledge with the bicycle in the summer. So some slides that I received from colleagues in UK. On the left side, a guy with a congenital myopathy learning the technique of the mouthpiece, but you see he can use his arm, so he's taking the mouthpiece with his fingers, but at the end it is better to have a collar, so you can have two free hands. Also, you see this slide from John Bach with a patient with post-polio syndrome. Here to show you that mouthpiece is the preferred interface for daytime use, and you see clearly when patients have increasing use of ventilation during the 24 hours, when they need ventilation more than 20 hours, clearly they prefer, the big majority of them prefer the mouthpiece. And also when they are using mouthpiece for more than non-invasive ventilation for more than 20 hours on 24, they prefer to use the mouthpiece, but they also prefer to use the volume cycle and not the pressure cycle. Quickly, patient benefits for mouthpiece compared to nasal mask during the daytime. There is less negative impact on the patient and also no risk for skin breakdown that we can see during the night time. And also shown by Brigitte Forroux, also less problems of facial side deformities. There is also a better speech. It is facilitating eating and swallowing. Patients report a better appearance. And also they see it is safer by permitting the use of glossopharyngeal breathing in the event of sudden ventilator failure. But it can be a risk of dental deformities. This is a risk we sometimes see in our patients. Here's some objective data regarding the benefits. Regarding speaking, for instance, this is speaking with the flow and the pressure during speaking with the nasal mask. And with the mouthpiece, we don't have this problem because when patients want to speak, they just release the mouthpiece and take it back when they want some more air. Here, something interesting and a little bit new, showing the difference between no MPV and MTV with the sustained phonation. And we see that with the mouthpiece, patients can have a longer phonation than with the nasal mask, and you see here the same with no. It's not with the nasal mask. It is MPV versus no ventilation, and you also hear that when we ask patients to count 1, 2, 3, 4, 5, etc., they can count until 3 without the MPV and until 6.5 with the mouthpiece. Regarding eating, an interesting work from the team of Lofaso with Nardi and colleagues here. And you see here in patient number 7, this is one of their series of patients, you see that during meal, when patients release the mouthpiece, you see that they can have some increasing in CO2 and also a little oxygen desaturation for sure at that time. And it is up to the patients to not have a too long period without ventilation when they eat. So what we advise to patients is to use the mouthpiece during meal and to have regular ventilation, for instance, every minute or every 30 seconds, because when they stay a too long period of time with no ventilation, they can have a rising CO2 and also some oxygen desaturation. The limitation and contraindication of the mouthpiece is the inability naturally to seal the mouthpiece. But for instance, in Duchenne, we had many patients with a big tongue, with macroglossia, and those patients were perfectly able, even without sealing the mouthpiece, to use the mouthpiece with their tongue. A second problem can be the inability to move the neck, but even patients with very few movement can use it. So you do not need to have large movement, but a little movement is mandatory. The biggest limitation is the impaired bulbar function, and our excellent colleague from Ottawa, Dr. Kim, told us that ALS patients with bulbar dysfunction can use the mouthpiece only with between 15 and 20% of the cases, which is a very low rate of success. Naturally, you always have patients who do not accept the trial with the mouthpiece when there is a poor compliance, when you have no equipment, but also sometimes when there is no caregiver or no family to switch the interfaces. My conclusion regarding this, the use of the mouthpiece is, now we have ventilators with mouthpiece dedicated mode, and this is commercially available. But if you don't have a dedicated mode ventilator, especially for the mouthpiece, for instance, with the PB560 or other device, you also can use it, but preferentially with the volume cycle mode. So this is the next point, the mode, volume cycle in first intention, because it doesn't compensate for leaks. If you want to use the pressure cycle, it is not easy to use, and when the patients really are dependent on the ventilator, our experience is that it's hard to use. But we found in some children, especially with SMA children, that they sometimes like to use the pressure cycle, and the reason is that there is a quick rising in pressure, and they like to have this feeling of quick stretching of the structures. Regarding the backup rate, you can adjust the backup rate on the ventilator when the patient is dependent on the ventilator, but when the patient has at least more than 3 hours autonomy without the ventilator, then you can set a zero rate, and probably the patient will like to use that. But remember, this is very important. The leaks are normal with MPV, and so please do not try to restrict the leaks that patients are using with their mouthpiece. So I thank you for your attention, and I want to attract your attention that there will be a next webinar on 30th of June, given by Alison Armstrong on the use of lung volume recruitment bach. That will be a very interesting topic. So I thank you for your attention.
Thank you very much, Michel, for this extensive and complete webinar and overview on the usage of mouthpiece ventilation. We have a number of questions here in the chat. I will try to bundle them together, and maybe we can start with the start of MPV, the initiation of MPV. There are some questions on how you do that. Is there a minimal required age before to start MPV?
Yeah, that's a good question. We spoke about that during our Amsterdam meeting in 2020, and we agreed that before the age of between 6 and 8, it is not easy. But yeah, it is also depending on patient cells. But before 6, 8 years of age, it should be challenging.
Okay, thank you. During the training period, do you take into account eating and drinking?
Aha, good question. Yes, sometimes when we think about it, but this is not part of the learning process. But you're right. You are right that it's something very important. But from the moment that patients can release the mouthpiece and speak, if they can speak, they also can drink. As you say, they very often drink with straws, and so it is not hard for them to eat and to drink, on the condition that they can release the mouthpiece. This is important.
Okay. Do you measure transcutaneous CO2 at the initiation of MPV?
Again, a good question, Carl. Yes and no. So we don't do that every time, but if you are using high tidal volumes, or if you see that patients are pursing the lips all the time, there is always a risk for rebreathing, and at that time I would advise to measure CO2, because our observation, and this is the observation of all the therapists using mouthpiece, is that very often mouthpiece is so effective that we have low CO2. And so the risk is not the high CO2, this is the low CO2. So if you want to be sure that you are not ventilating too much, it is a good option to sometimes try to measure some end-tidal or transcutaneous PCO2.
Okay. Yeah, one more around the initiation. Do you have some tips to improve the success rate if it's difficult to start MPV?
Yes, as I told you, so I wouldn't start immediately with difficulties. So the difficulty is to start with pressure mode. So if you start in first intention with the pressure mode, when patients feel the air in their mouth or on their face, they dislike it totally. So I would choose always to start with the volume mode. And also I would say be confident, because patients are looking at you, and if you are not confident with your equipment, they will feel it and you will lose them. Last point is be prepared. For instance, be prepared with the two mouthpieces, because you know in advance that 50% will prefer the plastic one, and 50% will prefer the straw, the silicone straw. So yeah, you can prepare everything to be ready when you start it.
Okay, yeah, you already touched on it, but I will ask the question as it's here in the chat. What do patients complain about during MPV, or what do they find uncomfortable?
What is very strange is that we have opposite reactions. Some are saying that they have lots of saliva, and others are saying that it is they have a dry mouth. So not easy to explain why one or the other one, but I would say you have to tell patients that it is not important to have those problems initially. Just try, and you will see you will manage that at the end. It will not be complicated. But when the indication is good in the beginning, the rate of success here is almost 90%. So I would say we have not so much patient who are not able to use it. But the very bad candidate for mouthpiece is the very clear bulbar problem patient. This is for sure a bad candidate.
Okay, thank you. There's two questions around the application a bit in a different way. There was one question if MPV can be applied in other pathologies, like, for example, COPD.
Yes, that's a good question, and indeed I didn't speak about that. So there are some studies in ICU, and also I think 2 studies in COPD patients, at least from France. Sorry, I don't remember the first name of the author. And they compared nasal mask and mouthpiece during the daytime with almost similar effects. So it can be done, but I don't have personal experience with those patients. Okay.
And they're asking about your experience also here, Michel, if you have experience with nocturnal use of MPV.
No, I don't have experience in, at least not with those commercially available mouthpieces. But I remember 15 years ago, we made a mouthpiece with the dentist in my previous hospital. We made that because we had a patient who was not able to use the nasal or oral nasal mask, and so we made something in the mouth for nighttime ventilation. But okay, this is really anecdotic.
Okay, there's 2 more questions. One is, you have not mentioned alarm settings. Do you use alarms and how you set them?
Okay. So indeed, I did not speak about alarming because if you remember, we spoke about the MPV dedicated modes, and quite all of them have the possibility to switch disconnecting alarm off and also apnea alarms off. Or you can also sometimes set alarms at 15 minutes. So patients can eat, can drink, can speak, can phone, etc. And when they don't use it for more than 15 minutes, then they will be alarming. But indeed, the idea of mouthpiece is lots of leaking, so very few alarms.
Okay. And then the last question, how to recognize MPV failure and what are typical causes of failure?
Sorry, how to
recognize MPV failure.
Okay.
And what are the typical causes of the failure?
Okay. I think that to answer shortly to that, if you try for 2 hours and the patient still does not understand what he has to do, it means that on that day this patient is not ready. I remember a patient who was psychologically not ready to use it, and I tried and I tried again and again and again, and finally he said to me, "I'm not prepared. I don't want to have that at school or when at work, for instance." And so psychologically, preparation is important. But yeah, if you use it more than 1.5, 2 hours with training, and patients still cannot use it, it means that he's not ready to use it. And as I told you, the biggest problem is probably the control of the larynx, probably.
Thank you. There's no further questions, so I would like to thank you very much, Michel, for your presentation today. It showed clearly all the experience you have for decades using mouthpiece ventilation, and thank you for sharing that with the audience today. To all of you attending this webinar, thank you very much for your time.